very, as you've surmised by now, I have limited respect for the HA's guidelines for the ST elevation and 2 anatomically contiguous leads measured at the J point, but 2 millimeters for men, 1.5 for women in leads V1 and V3. It's just like, come on, really, how hard are we going to work here to avoid teaching people the rule of proportionality? It just doesn't, it's just insane. Just explain to people why we're doing this, you know, and it has to do everything with the depth of the S waves in those leads. So anyway, you'll see as we go through the examples here that you don't need these criteria. So here's the chart that shows the anatomically contiguous leads. Again, leads V1 and V2, although they say septal, you might as well just throw them in with V3 and V4, because those are the leads that show ST elevation with LAD occlusion. Usually, sometimes more so-called extensive infarct, but let's start over here. Very simple. Inferior leads take up the lower left-hand corner of the 12-lead ECG paper. So 2, 3, and the AVF, they make up the lower left-hand corner of the ECG paper. Those are the inferior leads, okay? The most reciprocal leads, as you will see on the 12-lead ECG, are AVL and lead 3. So if you have ST elevation in lead 3 and the patient's having a STEMI, you're going to see your reciprocal change here in AVL, sometimes lead 1, but your go-to lead is really AVL. Sometimes when you have ST elevation in the high lateral leads, the so-called high lateral leads, those are sometimes referred to as electrocardiographically silent leads. So high lateral STEMI tends to be really, really subtle. Sometimes the most impressive finding are in fact the reciprocal changes here in the inferior leads, and I'll show you some examples of that as well. Again, septal leads, I usually group them together with leads V3 and V4 because V1, V2, V3, and V4, they're patients on the anterior chest, and then V5, V6, the so-called low lateral leads, low meaning they're down here on the chest, but they are anatomically lateral. You can see that. They're on the patient's lateral chest, so you know they're lateral leads. And then here up on the, the left arm, but the attachment point of the left arm is up here. So high lateral leads, the black electrode up on the left arm, 1 and AVL are derived from that black electrode on the left arm. So we call those the so-called high lateral leads, all right? So you got the lower left-hand corner, inferior leads, the high lateral leads, the anterior leads, and the low lateral leads. And that's kind of how it's laid out. But again, you got to look at the actual infarcts for this to make better sense. Similarly, we'll say the same thing about reciprocal changes here. It is true that the inferior and the high lateral leads are reciprocal to one another. So inferior ST elevation in 2, 3, and AVF, the reciprocal changes in the high lateral leads versus ST elevation in the high lateral leads, reciprocal changes in the inferior leads. Versus a isolated anterior infarct, you may have no reciprocal changes, which can pose some challenges, or the posterior infarct, a true isolated posterior STEMI, no ST elevation on the ECG at all, but we derive that they're having an infarct from the reciprocal changes in leads V1 through V4, okay? So, there's your charts for whatever good they do you right now. What we're gonna do is look at a bunch of these infarcts, and that's what's gonna drive the message home. Okay, the issue of right ventricular infarction, you can't always predict who will suffer the hypotensive syndrome, but there are some educated guesses that you can make. But step one is to determine whether or not it is actually right ventricular infarction. So I'm gonna share this case with you. It's an old case. This goes all the way back to 2001. It's when I first learned about modified right-sided chest leads, and this was one of my early experimentations with it. So this was actually a female patient. She was 79 years old. She was out shopping with her sister, okay? So we pulled up on this strip mall, and this woman was helped into the back of the ambulance, and we started taking her, her clothes off, whatever, and we're getting her first set of vital signs and things like that. We're asking her questions about the history of the present illness. I always ask patients, what were you doing when I get my OPQRST, I ask, what were you doing when the pain started? And I ask, has this ever happened before? Those are two super useful questions that can kind of like keep you between the ditches, because I've actually had patients where I've said, what were you doing when the pain started? Well, I was walking up the stairs. Has this ever happened before? Well, yes, I have chronic stable angina. Oh, So today's team was predictable? Yeah, I thought so. Well, why'd you call 911? I didn't, my daughter did. That's a different scenario, isn't it? Than someone saying I was walking up the stairs. No, it's never happened before. You know what I mean? It's just like it helps you piece together what's going on. So, you know, what were you doing when the pain started? And has this ever happened before, in addition to your open QRST? Anyway, this woman says, yes, it has happened before. Like I was shopping when it started. Yes, it's happened before. Oh, when did it happen? When I had my heart attack, she said. Okay. And how would you say today's pain is compared to the day that you had your heart attack? And she said, it's exactly the same. Exactly the same pain. So pretest probability now, we say high or low? It's high. Haven't even hooked her up to the monitor yet. We got high pretest probability. This woman's not her first rodeo with a heart attack. So get her in the back of the ambulance, and this prints off right here. We're gonna run through our little scenario. What's the rate and rhythm? Heart rate is 68. Would you say this is regular or irregular? It's regular. QRS duration, 104 milliseconds. Is that less than 120? Yeah, so we have narrow QRS complexes. If we go over to lead 2 here, we have P waves in a one-to-one relationship with the QRS complex with a normal PR interval. Pretty normal, yes, normal PR interval. So we have sinus rhythm on the monitor. Okay, where is our ST elevation on this ECG? 2, 3 in AVF. Okay, so lower left-hand corner, we have ST elevation 2, 3 in AVF. Let's go to our magical rule in lead AVL. Do we have a reciprocal change? We do, okay? You know, in our system, that's like dispatch medic 3, code STEMI, you know, at that time to get our timestamp, okay? Now, in this case, you'll notice we don't have reciprocal changes in the right precordial lead, so we're not seeing signs in this particular case of posterior extension of this acute inferior STEMI. It's not always there. It's very frequently there, but it's not there in this case. Now, I thought to myself, I wonder if this could be right ventricular infarction. Another way to ask that question is, I wonder if this could be a proximal occlusion of the right coronary artery to where it's knocking out the right ventricle on its way down to the inferior wall of the left ventricle. So I had read this article by H.J. Wellens that basically showed it's got pretty good sensitivity if you just unsnap lead before and snap it onto a new electrode and move it all over to the mirror image position on the patient's right side of their chest. That if we have ST elevation there, that helps rule in the possibility of right ventricular infarction. So here's a diagram of what that looks like. So we've unsnapped the electrode here, snapped it on a new electrode, we've moved it over to the right side of the patient's chest, and we're gonna obtain another 12-lead ECG, and here it is right here. So even though it's kind of strange looking, blown it up so you can see it, do we have a millimeter of ST elevation here in lead V4R? When we do that, by the way, we put an R at the end to let everyone know that this is on the right side of the patient's chest. It's in the position of lead V4, but it's on the right side, so we call it V4R. And yes, kind of strange looking, but it does have a millimeter of ST elevation, but you'll also notice QRS complex is very small. So rule of proportionality applies anyway. So this is a significant amount of ST elevation. So now we've decided, yes, this patient has a strong probability of right ventricular infarction. Now her first blood pressure was like 100/50. So it's like, you know, I'm a gambler. Is there gonna be nitro today or is there not gonna be nitro today? I've got right ventricular infarction. So we thought, well, this makes sense. We're gonna start an IV and do a preemptive fluid bolus and then do a trial dose of nitroglycerin. This is what we decided, okay? So we started an ECG. We started an IV, we give her a fluid bolus. It brings her pressure up to like, I don't know, 120/70, something like that. It gives us a little more room to play. And we did a trial dose of nitroglycerin, which brought her pressure all the way back down to like 98/60 or something like that. And I'm like, okay, I'm stopping right there. I don't like what happened with my little trial dose of nitroglycerin. That's playing it a little too close right there. Whether I should have done that or not, I still wonder about to this day. Like, should we be messing with nitroglycerin at all if there's a possibility? I think that it's a clinical judgment. I think you have to look at the patient's vital signs. I think you have to look at their heart rate. I think it's very wise to get an ECG, an IV, do a preemptive fluid bolus, if you're going to do that, okay? But the world, the way it works, at least in the United States, if this patient codes and goes into VFib through no fault of the nitroglycerin, it's gonna look like the proximal cause was you giving nitroglycerin. It is technically contraindicated in the setting of right ventricular infarction. And by the way, very little evidence in the reperfusion era that it provides a mortality benefit. This patient needs the cardiac cath lab, more so than they need nitroglycerin. But, you know, it's just one of those things that requires clinical judgment. You know, I'm not going to say follow your protocols, that's what everyone always says. But so this is just what we did on this particular day. Now, I brought this patient into the emergency department, and I tried to have one of those collegial conversations with the attending physician, who had no interest in my commentary whatsoever and literally walked around me and walked into the patient's room. I was completely ignored. I was trying to tell this physician about right ventricular infarction. I was not given the time of day. So I was like, well, there you go. So I sat down, started filling out my patient care record, and then there was a bunch of commotion happening in the room. And I saw people running in and out and running to the Pyxis and everything, so my ears are perking up a little bit, and I'm like, what's going on in there, right? Well, the patient's blood pressure has plummeted, they said. And I said, really? What have you been doing in there so far? Well, we put the patient on a nitro drip and we gave 10 milligrams of morphine. Did you indeed? So, my friend who, the unit secretary, I just said, hey, can you print out, because they can print remotely a 12-lead ECG from the desk there, and it prints out at the printer behind the nurse's station, whatever. I said, can you print out the 12-lead ECG? So you can see this right here, when we've identified right ventricular infarction. I'm gonna show you the next ECG now that the patient's blood pressure is bottomed out. This heart rate right now is 65. I will tell you the heart rate in the next ECG is about 80. But I want you to pay attention to lead V1, the amount of ST elevation in lead 3, just to the whole impression of the ECG and tell me how much you think things are getting better or worse at this point for the patient. Seem to be getting a little bit worse, okay? Drop this patient's blood pressure. This is anecdotal, I realize. Can we blame it on right ventricular infarction? You tell me. It sure looks to me like this patient is having a negative hypotensive reaction to nitroglycerin in the setting of right ventricular infarction. At any rate, cath lab, they do a fluid bolus, and the cath lab team now is down in the emergency department, and the caravan is starting to head to the cardiac cath lab. So I grabbed my paperwork and I followed them, okay? Like, I want to see the end of this story, is basically. So I just walked right in. Hey, do you guys mind if I fill out my patient care report right here in the monitoring room? They're like, no, have a seat. So I watched the procedure, okay? So they got the patient attached to the monitor up in the cardiac cath lab, so you can see the amount of ST elevation. The next ECG I'm gonna show you is after they crossed this lesion with a wire, and it did turn out to be a proximal RCA occlusion. So this is before, and you'll notice in the next that we have greater than 50% resolution of ST elevation, and boom, that's after they crossed the lesion with the wire and restore blood flow to the patient's myocardium. And I will never, ever forget this. The patient was under conscious sedation but could still speak. She said, oh, I don't know what you guys just did, but I feel so much better. And I was like, wow, wow. We can debate whether we should give fentanyl versus morphine or some other analgesic, but you know what makes these patients feel better? Reperfusion, okay? Fix the underlying cause, and these patients feel a lot better. So that's my right ventricular infarction story. Why QRS rhythms, fast or slow, are ventricular until proven otherwise. So number one, we want to make sure that we have a supraventricular rhythm. The easiest way to do that is just to confirm that we have one-to-one relationship between P waves and QRS complexes, but it could also be atrial fibrillation or something like that for us to suspect this is a supraventricular rhythm. That's rule number one. Rule number two, we want a wide QRS complex. Again, our definition for that is 120 milliseconds or greater that would constitute a wide QRS complex. When supraventricular rhythms are wide, we go to lead V1 and we try to differentiate them and say, can we sort this into right or left bundle branch block? So in this particular case, we always start with rate and rhythm. Again, right here, the rate is 75. Since that is one of the rates that falls into the large block method, gee, I wonder if there's 4 large blocks in between our waves here. And yes, you can see 1, 2, 3, 4, exactly 4 large blocks between our waves that we can confirm with our own eyes that yes, indeed, the heart rate is 75 here. We also look at this ECG and we ask ourselves, is this regular or irregular? It's actually very satisfying looking at this ECG. It looks very regular. So we have a regular rhythm at a rate of 75. And what is the QRS duration? 146. Is that greater than 120? Yes. So we have a regular YQRS rhythm at a rate of 75. Well, let's go hunting for P waves here. In several leads, we can see P waves that are in a one-to-one relationship with the QRS complex with a constant PR interval, and the P wave morphology is constant. So we think now that this is a sinus rhythm at a rate of 75 with a YQRS. That's a supraventricular rhythm. When supraventricular rhythms are wide, we go to lead V1. Remember what we said for the normal ECG is the QRS complex should start out negative in lead V1 and end up positive in V6 with a transition somewhere around V3. But in this case, we don't have a negative QRS complex in lead V1. We have a positive QRS complex in lead V1. This is our first clue that we might be dealing with a right bundle branch block. So, why? Why do we have a terminal R wave in lead V1 with right bundle branch block? Let me ask you a question. If the right bundle branch is blocked, what ventricle depolarizes first? The left. If the right bundle branch is blocked, the left ventricle depolarizes first. Because that is true, it means we have late left to right ventricular depolarization. Now, one of the basic concepts of electrocardiography is when a depolarization wavefront moves toward a positive electrode, you get an upright signal in that lead. What is the only positive electrode on the right side of the patient's chest? Lead V1. Because the right bundle branch is blocked, the left ventricle depolarizes first, and we have late left to right ventricular depolarization, and that late arrival of that depolarization wavefront is headed right toward the positive electrode in lead V1, which is causing a late positive deflection in the QRS complex in that lead. And we'll start with concordant ST segment elevation. Is there any ST elevation concordant with the QRS complex on this ECG? Yes. It happens, by my reckoning, 3 times on this ECG. In lead 2, and also in lead V5, and also in lead V6. We have concordant ST elevation, okay? Second question, is there any ST depression in lead V1, V2, or V3? Well, yeah, there is. We have ST segment depression in leads V1, V2, and V3. It meets Sgarbossa's second criteria. Does it meet Sgarbossa's third criteria? Close, close. We're at about like 4 3/4 millimeters there in lead, very, very close in lead 3 to meeting Sgarbossa's criteria, third criteria. But that's okay, because someone came along and modified Sgarbossa's third criteria. This is sometimes referred to as Smith's modification of Sgarbossa's criteria. And he introduced the rule of proportionality to that third criteria. And it's basically, is there excessive discordance? Is there ST segment elevation that is at least 25% the depth of the S wave? Now, for my liking, this is still too complicated for field use, because now you're expected still to do math. I have a workaround for that, okay? My workaround for Smith's modification to Sgarbossa's criteria is to count the number of large blocks of S-wave depth, and I round up, okay? So if you look at this case right here, the S-wave starts right at this line here. We have 1 and 1.5. So we have about 7.5 millimeters. I'm gonna call that 2 large blocks of S-wave depth, because I round up. That means I will allow 2 millimeters of ST segment elevation in that lead, but not 3. Okay, that's how I adapt Smith's modification for field use. How many millimeters of ST elevation there? We have almost 5, like 4.5, 5. Is that greater than 2? Yes. That is how you can adapt Smith's modification for field use. Count the number of large blocks of S-wave depth, and that is how many millimeters of ST elevation you should allow in that lead for left bundle branch block.